What is this? Clubbing. Okay, huge topic. Now we are entering into huge chunks. Clubbing, cyanosis, pedal edema, huge topics, very huge. Okay. First, what is the definition of clubbing? Most oldies will torture you with this only. Tell the definition, define clubbing. That's how exactly they tell, no? Define clubbing. It is like whenever I see those kind of mannerism, no, in exam, I feel like in WWE they call, no? It's like that. It's a fight between Big Show and Rey Mysterio. It's like that, no? Okay. So what is clubbing? Define clubbing. Anyone can define? I mean, just tell, try attempting. Huh? Bad. You can speak a little loud. Obliteration of nail bed angle. That's not definition, that is a sign of clubbing. Obliteration of nail bed angle. Okay, it's a focal. Okay, number one. Entire finger is not involved, isn't it? Only distal part is involved. So focal and selective. Very selective. Not the entire distal phalanx is involved. Only the nail bed area is involved. So focal and selective bulbous enlargement. Focal and selective bulbous enlargement of the distal part of the distal phalanx. Of the distal part of the distal phalanx due to selective proliferation of subungual connective tissue. This is clubbing. Due to selective proliferation of subungual connective tissue. Focal and selective bulbous enlargement of the distal part of the distal phalanx with due to selective proliferation of subungual connective tissue. That is clubbing. How clubbing will look like? You want to tell one more time. Focal and selective bulbous enlargement of the distal part of the distal phalanx due to selective proliferation of the subungual connective tissue. That is clubbing. Okay. So if I am an examiner, I will not expect anything. I will say, what is clubbing? Enlargement of the distal part of the finger, that's all. That's clubbing. I need that much only. If you know how to find out clubbing, that's more than enough. Rather than like telling the definition. The nails will be shiny and it will be convex. That's the characteristic feature of clubbing. Shiny convex nails. Nails look very shiny and they look convex. Very important sign of clubbing. It can happen only in fingers or it can happen in fingers and toes. It can happen in both fingers and toes. Okay. It doesn't mean that happens only in fingers. It can happen in both fingers and toes. Is there any idea about where your first clubbing will happen in which finger? Wow. Okay. Which index finger, right or left? Select one. Right. Right is right. Okay. Right index finger. I mean, that's what they say, but I'm not very much interested in all these things. But anyway, that's what the idea is. Right index finger probably is the first finger to probably, like develop clubbing. That is why some examiners are very particular about doing shamrock sign with the index finger rather than the thumb. They'll ask you why you want to do the index finger first. So you need to say that clubbing theoretically first starts in the index finger only. So that is why shamrock sign, instead of doing like this, do like this. Okay. I mean, crazy questions, like, so they might ask something like this. So if you don't know this explanation, you will be just asking like, why man, why I'm saying index finger means your face. That's why I'm saying index finger first. So you have to answer this. That's what they expect. Okay. Because I've been with so many examiners. How means? Because I used to organize these kind of exams, practical exams in my college. Because I did my both undergraduation and post-graduation KMC only. During UG also, I'm a very reputed person to conduct these exams. This snacks, tea, coffee, so that and all. So we call it as clerical work, no? So that I do. In PG also, I am the one who's to arrange the cases and all. And sometimes, like if there is a beautiful girl, we'll give a good case. So yeah, I'm a male man. Obviously, I'll have that attraction. What do you think then? So if I say that no, I'll be equally giving easy cases to both males and females, like that doesn't work. See, I'm not a saint, obviously. I agree with that. So if I say like that only, I'm lying. So obviously, my orientation is straight. So I have a straight orientation for your information. So I don't have any issues in giving easy case to little beautiful girls. Okay, jokes apart. By the way, so this is what is there. So what happens is that time I used to stand with the examiners. So many times I'll be standing, sir, you want tea? Sir, coffee. So I know the timing also. Whenever a candidate is getting frustrated, that time I'll give mixture. To stop them from asking questions. What to do? See, whatever I can do, no? So to help the candidate. So give mixture or give biscuit. Sir, lunch, what do you want? So this is what we can ask. Whenever a candidate is getting harassed, this is the help we can do. So by the time the internals should take over, but that bloody buggers will be on the phone during that time. So these are some problems that happen. But anyway, we try to help as much as possible. Because when you don't teach them, you are not fit to ask sufficient number of questions. That's what my idea is. If you teach them, rip them in and out. Doesn't matter. You can ask any amount of questions. If they don't answer, you fail them. But if you don't teach in the first place, you ask so many questions, what they will do? All the examiners will become super teachers on the examination day. I don't know why. Isn't it? Yes or no? See how much voices are coming. All the examiners, seriously, they become super duper teachers on the exam day. But prior to exams, you can't even see their heads, where they went or where they are. I mean, not a very good state for medical people, especially current students. That's why. Okay, what is the pathophysiology of clubbing? So we have many hypotheses. It's very boring actually. But anyway, examiners ask what to do. So number one is platelet hypothesis. This is the most accepted and widely recognized hypothesis. So accordingly, what they say is the pathology consists in the megakaryocytes. Okay, this is the way how to relate two things which you feel it's completely unrelated. They relate megakaryocytes with clubbing. How? Because they believe in, for example, these megakaryocytes, they get broken down in the lungs. Generally, they get broken down in the lungs. Basically, these megakaryocytes. Suppose if the lung function is poor, or if there is some cyanotic congenital heart disease where there is a shunting from right to left, or pulmonary AV malformation or AV fistula of any cause somewhere. So what happens is these megakaryocytes escape these lungs and they go into the peripheral circulation. So they bypass the lungs and they enter the peripheral circulation. In the periphery, in the small distal nail bed, and nail bed capillaries are known to be extremely small. And in the peripheral distal nail bed capillaries, they get broken down because they cannot pass any further because they are very small capillaries. Megakaryocytes are mega, big. So they will not be able to pass any further. If they're not able to pass any further, they start residing there and they get broken down and they release some local factors like VEGF and PDGF, of which people believe that PDGF is the most important. People currently believe that PDGF is the most important. Periphery. So this is probably the reason for, because VEGF and PDGF are growth factors. The name itself says, as an undergrad, at least you can understand it's a growth factor. So they're going to increase the connective tissue in that area, in the distal part of the nail bed. So, but still it doesn't explain a lot of things. For example, how will you get how will you get clubbing in gastrointestinal causes? How will you get clubbing in thyrotoxicosis? Doesn't explain a lot of things, but this is the currently most accepted hypothesis. Second, we have humoral theory. This is the easiest theory. In the humoral theory, they say some unexplained humoral substances are causing clubbing. Some humoral substance is there, which is unknown. What is there? It is causing clubbing. Example is acromegaly causing clubbing. Acromegaly can cause clubbing, basically. So example is that. Probably the candidate could be growth hormone also. We don't know. Then persistent hypoxia, that's called hypoxic theory. it's believed that this hypoxia opens up the AV fistulas. I mean, even in certain areas, it's believed that AV connections are common. For example, in the fingertips, in the eyes and all, they believe that AV connections are common, in the especially in the small capillaries. In hypoxic situations, because of to increase the blood flow to the end organs, this capillary AV connections will widen up and open, so that they believe that could be the reason for development of clubbing. But I don't know anything beyond that. Even it doesn't make any sense to me also, like how it doesn't make any sense to you. Okay, then there is something called low ferritin theory. Okay, they believe like low ferritin in the peripheral circulation, systemic circulation, can cause dilation of AV anastomosis and hypertrophy of the terminal phalanx. Because of opening of the AV connections in the distal nail bed, more blood flow to the distal nail bed, proliferation. That's what they believe. Initially, what they said, hypoxia is causing this opening of distal AV connection. In this theory, they are telling low ferritin is the reason for opening up of distal AV connection. So in both the situations, more blood, more proliferation, more nutrition to the distal phalanx. Okay. Number 5, vagal theory is there. What is vagal hypothesis? Persistent vagal stimulation is known to cause vasodilation and clubbing. Because vasodilation, more blood flow again, and more proliferation of connective tissue. That's what they believe. So what is the evidence for this? With vagal theory, what you can explain? Bronchogenic cancer, lung cancer. Bronchogenic cancer is thought to cause clubbing by this mechanism only, vagal hypothesis. And what is the evidence for this? Vagotomy can reduce clubbing. People have experimented with doing vagotomy. After doing vagotomy, clubbing disappears in certain patients. Not all, if at all. So that is another evidence to this hypothesis. Next, we have something called toxic theory, where they believe some toxic products like cytokines or that bacterial toxic products can result in clubbing. This explains the infective endocarditis causing clubbing. Because infective endocarditis, you don't have any shunting at all. No peripheral dilation. Still you get clubbing. Then how can you explain toxic theory? Some toxic substances in the form of cytokines or probably in the form of bacterial toxins can result in development of clubbing. Then finally, last 2 is there. You have estrogen theory also. So they couldn't explain how cirrhosis patients are having clubbing. So they said hyperestrogenemia in cirrhosis is the reason for clubbing. So cirrhosis and clubbing is explained by estrogen theory. Finally, we have, last but not the least, metabolic theory. This metabolic theory explains thyrotoxicosis causing clubbing. Thyrotoxicosis is a well-known cause of clubbing. Thyrotoxicosis can cause clubbing through metabolic hypothesis. So we have, I mean, not even a single hypothesis can help understanding every single cause of clubbing. Each and every hypothesis has its own speciality, and each and everything tells about a unique cause of clubbing. That's why all these theories are asked in the exams by the examiners, because with one theory alone you cannot explain every single cause of clubbing. That's the problem. And as of now, nobody knows the exact genesis of clubbing. That's the problem. And clubbing can be either acute or chronic. Acute versus chronic clubbing. So acute means less than 6 months. Chronic means more than 6 months. Okay, clubbing takes more than 6 months to develop. Acute means clubbing develops within 6 months of onset of a disease. So which place you will develop acute clubbing? Within 6 months. Empyema. Okay, it's believed that lung abscess and empyema causes the fastest clubbing. Lung abscess, empyema. You can see clubbing as early as 2 weeks time. Within 2 weeks, you get clubbing in lung abscess and empyema. Then probably you can see in infective endocarditis, approximately within 3 weeks, you can see clubbing in infective endocarditis. Very fast. Then last but not the least, it's mesothelioma. Mesothelioma, it takes approximately 3 to 4 weeks to develop clubbing in a mesothelioma. Bronchogenic cancer generally takes around 6 to 12 months to develop clubbing. It's not an early sign. Mesothelioma causes clubbing in 3 to 4 weeks. What about chronic clubbing? Clubbing develops beyond 6 months. One is, of course, cyanotic congenital heart disease, which takes approximately 6 months to develop clubbing. Generally, after the onset of cyanosis, it takes around 6 months to develop clubbing. That's a number that you need to know, surely, for exam. Then you have other diseases like bronchiectasis and ILD. Bronchiectasis and interstitial lung disease. In these situations, it takes approximately around 1 year to develop clubbing. That's why they say that in ILD, clubbing is a late sign. Especially in ILD means practically IPF, idiopathic pulmonary fibrosis. So in ILD, it takes around 1 year. It's a very late sign. Clubbing is not an early sign in ILD. What are the ways to evaluate clubbing? I told you the definition: first finger to be affected, pathophysiology, acute versus chronic clubbing, time frame for developing clubbing in different disorders. Then what are the signs for, what are the ways to check for clubbing? I'll tell you later on. I'll show you each and everything. But important ways are Shamroth window test. We know that. Second, test of Lowy-Bond angle. You're going to see from this side, Lowy-Bond angle. Then we have something called Kurth angle. Not Kurt Angle from WWE. I mean, everyone knows Kurt Angle, right? I mean, right now he retired, I think. He's not wrestling anymore. He was an old wrestler, I guess. He was the only wrestler with, I think, in the WWE with Olympic gold medal. That's why he comes with that medal always. And he puts that America music. Tan, ta, da, dan, ta, da, dan, ta, da, dan, tan, tan. No, you're not heard. Okay. So it's not Kurt angle, it is Kurth angle. C-U-R-T-H. Kurth angle. Obviously, like boys, how many of you see WWE even now? 1, sorry, 2, 3, 4. Yeah, definitely there must be someone who sees WWE. I mean, even now I see, that's why. I know it's fake, but what to do? I've been seeing I started believing from when I was 6 to 7 years of age that Undertaker has 7 lives. I really believed it, man. When I was 7 years of age, I believed it, to be honest. Now I know it's a fake, but that belief is still happening. And even Undertaker is also retired recently, by the way. Anyway, then what else you can look for? You can look for something called DPD-IPD ratio. That's called distal phalangeal diameter versus interphalangeal diameter ratio. Then you have something called digital index. You have 5 ways to assess clubbing: Shamroth sign, Lowy-Bond angle, Kurth angle, digital index, and DPD-IPD ratio. All these things will be asked in exams. But before that, let me look at the Lung India grading. So this is the only reliable grading system that is available. Even though different books will give different grading, especially Indian textbooks. I think authors' own grading system they will give, I think. But the only accredited grading system in India is Lung India grading system. So based on that, you have 5 grades of clubbing. But I don't know, again, follow your local policies. Some examiners in your hospital may say 4 grades of clubbing. I can't predict, but this is from Lung India grading. You can go and search it in the Google also. This is what is available in an accredited fashion. Everything else is subjective only. What is 1? Only fluctuation will be positive. And why we get fluctuation? That is because the softening of the nail beds. Remember, normally nail beds are not soft because of limited connective tissue. When you have increased connective tissue, nail bed will become soft. So once the nail bed becomes soft, the fluctuation test will become positive. So that is softening of nail beds. Grade 2 is loss of Lowy-Bond angle. What is the normal Lowy-Bond angle? Less than 160 degree. If it becomes more than 160 degree, that's called loss of Lowy-Bond angle. Ideally, more than 180 is what we call as loss of Lowy-Bond angle. But okay, not a problem. Then what about 3? 3 is accentuated convexity. I mean, or simple terms, some people call it as parrot beak appearance. Accentuated convexity. The nail will be more convex and look like a parrot beak. And 4 is clubbed appearance. This is what the exact nomenclature that is given. Clubbed appearance of the fingers. Otherwise, you can call it as drumstick appearance also. But that word given in the grading system is clubbed appearance. But you can imagine that is the same as that of drumstick appearance. Like as if, like people who do the tawil, they put that something. What is that? I don't know. Any people who do tawil here? as a hobby or extracurricular activity? Any boys especially who do tawil? Extracurricular activity? Huh? Okay, I think you'll do tawil only when girlfriend is there. Okay, fine. Isn't it? No. Maybe you can show your magic. Okay, sorry. Okay, 5. So then conversation will become bad. Okay, then 5. What about that? 5 is development of shiny and glossy change. Shiny and glossy change in the nail and the adjacent skin. Technically speaking, with longitudinal striations will be there in the nails. So nail look very shiny, skin also around it will start looking very shiny, which means it is due to some neurovascular changes that's happening nearby. So that is grade 5. So this is the exact lung India grading. So maybe you can say fluctuation, large bone angle, parrot beak, drumstick, and skin changes, local skin and nail changes will start happening. So this is the 5 grades of clubbing. So what they are trying to do here? What are you trying to do here? So you're trying to do fluctuation test here. Okay, that's you're testing for the softening of the nail bed. You're trying to test for fluctuation. Very difficult to pick up. Honestly, it's not at all easy. Only in theory it exists basically, and the reproducibility of this sign is extremely poor with a positive predictive value of as low as 5%. There is absolutely no inter-examiner approval on fluctuation test. This is why many modern clinical like examination textbooks have ignored this fluctuation test as a very important sign. Okay, so it's very much variable between people who examine on the same day itself. So it's not something that is very easy to pick up also. So, but how to do that? Technique at least is very important. So you have to support the base of the thumb. Okay, that's very important. And you have to support the proximal interphalangeal joint with your middle finger, and your index fingers should test for the fluctuation. And you have to press on both the sides so that you can see the displacement of another finger. That is because of increased connective tissue that causes a kind of softening. So it causes displacement. Ideally speaking, this is something that's an absolute nonsense for me. Why? Because fluctuation will be positive only if there is a fluid in an area, technically. And how can a tissue can produce fluctuation? I don't get it since my UG days. I don't really get it. Okay, there is a variation of this sign. How to look for? I think, where is that? Yeah, here is the variation. And some examiners say this is how you do it. So rather than using the fingers, because this is at least little better. Because in finger, it's a big finger, man. How to see the displacement like this microscopically, I don't really understand. But at least this is a pin. So you can see the displacement of the pinheads at least to some extent. Do you understand? Okay, probably I can tell Dr. Dilip's variation actually. I generally ask the students to use finger on one side and bell pin on other side, so that it's even more easily visible. That's what I tell my students. If you really want to look at fluctuation, this is my variation I do. But any examiner can have his own or his or her own variation. I use like that, one finger and one bell pin. So this is easy. It's a hybrid technique. So finger to press harder, and small fluctuation also will be visible in the pinhead. Both pinheads means it's very difficult to give sufficient pressure, and the pressure is exerted only on a small amount of area. That may not be sufficient to elicit a fluctuation because it's not fluid there. It is connective tissue, soft tissue. So technically it's very difficult. So this is another variation of clubbing. So this is another way to do clubbing, as I told you. Another variation of how to do a clubbing. And what is this one? What is this? Something you can see here. What is this? That's called Shamrock's window. Okay. So many times, like during, these are very cheap fun we do in our college days. What we do is we try to see the girl of our interest with the window like this. Okay. If we see in the window, if that girl also looks at us, it means that girl is interested in us. This is during our time. Very outdated, no? Generation gap is there. Even now you do. No, you don't do. Very outdated technique. But still, We used to do these kind of ones because those days we don't use that much of phone. So anyway, we used to do this kind of things only, stuff. Okay, what is this? But if the patient is having clubbing, you cannot get any girlfriend no matter what, because you cannot see the window. Isn't it? So the window is obliterated. That is because of the proliferation of the subungual connective tissue that obliterates that Shamroth window. As simple as that. So what is this basically? What you're seeing here? What is image number A? What is image number A? Image number A is the normal Lowy-Bond angle. Okay, normal Lowy-Bond angle is approximately around 160 or less than 160 degree. So it's the angle formed between the nail and the nail bed. So this is the, probably you can say it is nail bed, and this is the nail. Okay, so proximal nail bed versus the nail. What is the angle that is formed? So that is the normal Shamroth sign. And the problem is, as the connective tissue starts proliferating from down, what happens is this angle will become either straight or it can become like this also. Are you understanding or not? That is the reason why if it becomes straight means it will become what? 180 degree. As the clubbing increases, this angle will become more than what? 180 degree. Are you understanding? The reason is, normally there should be simple. Normally there should be a step. Okay, between the proximal nail fold and the nail, there should be a step, small step that should come down and the nail will go like this. But because the proliferation of connective tissue, that nail will start getting up and the angle becomes straight first. Then after that, it will become concave. So this is loss of Lowy-Bond angle. Very simple. Many people confuse this Lowy-Bond angle like anything. I don't know why. It's very, very simple actually. It's one of the easy signs to pick up in clinical medicine as well. And it has at least some decent inter-observer variability of approximately around 20 to 25% only. Not very much variable, and acceptance within examiners are very similar. And it's having a positive predictive value of approximately 99% if you pick up the loss of Lowy-Bond angle. So it's a useful test, to be honest, if you want to look at. This is the normal Lowy-Bond angle. Okay. So then you have a clubbing. Okay. So here you can see what is happening here. So here you can see the nail, proximal nail bed like this. And then you can see the step here. Okay, that is the reason for that Lowy-Bond angle in the first place. Here you can see there is a proliferation of this connective tissue here. So that is the reason why you can see the Lowy-Bond angle become more than 180 degree in a normal nail. I mean, a clubbed nail. But what is this one? I didn't say this thing. What is this? This is called as Kurth angle. This is what I'm talking about. Kurth angle. So what do you mean by the Kurth angle? Kurth angle is a much simplified version of the Lowy-Bond angle. In the sense, Lowy-Bond angle, some people don't understand properly. That's why Kurth is called as Kurth angle is also called as modified profile sign. Modified profile sign. And Lowy-Bond angle is also called as profile sign. The other name for Lowy-Bond angle is profile sign, and the other name for Kurth angle is modified profile sign. So what is Kurth angle? It is the angle between the proximal and the distal phalanx itself. That's all. Very simple. It's not the nail bed, proximal nail bed, nothing to do. It's the angle between proximal and the distal phalanx itself. Normally speaking, how it should be the case. If we see here, the angle between the proximal and the distal phalanx, it's approximately around 180 degree. Isn't it? It's straight actually. Even if you can see the finger, there is no difference between proximal and distal phalanx. It goes straight. Normally it is 180 degree. Okay, you cannot see any curve between proximal and distal phalanx on the dorsal aspect, not the ventral aspect, of course. In the dorsal aspect, you cannot see any difference. It just runs straight. Okay, but if it is less than 180 degree, but we cannot give exact 180, 160 degree especially, which means what is happening is there is a convexity because of increased connective tissue in the distal part of the nail and nail bed in the distal phalanx. The distal part of the nail is growing and becoming bigger. So this angle, instead of being straight, it becomes less than 180 degree. Or we can say less than 160 degree by definition. That's what we call as Kurth angle. Kurth angle is nothing but the angle between the proximal and the distal phalanx, middle and the distal phalanx. I'm sorry for that. So Kurth angle is the angle between the middle and the distal phalanx. Okay. So if you take the two angles, let us assume one is Lovibond angle and second is Kurth angle. Lovibond angle is profile sign, Kurth angle is modified profile sign. So remember, a normal Lovibond angle is technically more than 160 degree. Okay. But if it is, what is abnormal? Sorry, normal Lovibond angle is less than 160. Okay, that is normal. Less than 160 degree. That is normal Lovibond angle. What is abnormal? If it is more than 180 degree, especially if it's considered to be abnormal. On the other hand, Kurth angle, normally itself it should be more than what? 160 degree. Anything less than 160 degree is what we call as abnormal. So normally, ideally, it should be around 180 degree. Normal Kurth angle is 180 degree. If it's less than 160 degree, it is abnormal. So very different. Even the definitions are different. Angle between proximal nail bed and the nail itself is Lovibond angle. Angle between the middle and the distal phalanx is called as Kurth angle. And what do you mean by DPD-IPD ratio? That's also very, very important. If you see this picture, you will be able to get that dotted lines. If you see, you will be able to get what is DPD-IPD ratio. So this marking from C to D is DPD. What is DPD? Distal phalangeal diameter. That is DPD. This is interphalangeal diameter. So where you are going to see at the junction of the middle and the distal phalanx. That is interphalangeal area. So interphalangeal diameter. Normally, by this is a normal finger. By this, what is more? DPD is more or IPD is more? Which is more basically? IPD is more. So if you do a DPD-IPD ratio will be less than 1 or more than 1? Less than 1. Technically, it should be less than 1. That is normal DPD-IPD ratio. But in early clubbing, that ratio becomes approximately equal to 1 because the DPD proliferates. Okay, that's because of proliferation of connective tissue, the distal phalangeal diameter increases. In late stages of clubbing, as you can see, what happens here? In late stages of clubbing, the DPD diameter actually is increased more than the IPD diameter. So the ratio will become more than 1. So in early clubbing equal to 1, in late clubbing it becomes more than 1. So that is DPD-IPD ratio. Yes or no? Simple. Okay, now the final thing, digital index. This is very easy again and very difficult to do also. That's called digital index. What is DI, digital index? What they tend to do is they tend to add the diameters of the proximal phalanx, distal phalanx. So distal phalangeal diameter of all the fingers. That's why I wrote sigma there. All the fingers means especially except the thumb. So fingers 2 to 4, 2 to 5. First finger is thumb, right? So from fingers 2 to 5, you're going to add all the distal phalangeal diameters divided by sigma interphalangeal diameters of fingers 2 to 5, which means you're going to add all the interphalangeal diameters from fingers 2 to 5. Once again, if the ratio is less than 1, it is normal. Equal to 1, it is early clubbing. And if it is more than 1, it is late clubbing. That's all. It's very similar to DPD-IPD ratio only, but here it also utilizes your DPD and IPD of all the fingers except the thumb. Of all the fingers you're going to utilize, not just one finger. So that is the digital index. So very, very similar to DPD-IPD ratio only, but you're going to add upon all the diameters. That's all. Now as we move, what are the causes of clubbing basically? Cause of clubbing. Clubbing is a spotter, isn't it? So what are the cause of clubbing? Generally, you can remember the mnemonic C, okay? C's. C. Mostly it will be C's. C is the mnemonic. So first you see all the systems. Most important systems are what? Cardiac and pulmonary. So what is the cardiac cause of clubbing? Everyone knows. What is the C? C stands for cyanotic congenital heart disease. Cyanotic congenital heart disease. Then another C stands for carditis. What kind of carditis? Infective endocarditis. That's what I mean. Another C stands for cancer. What cancer? Atrial myxoma. Can well produce clubbing. Atrial myxoma. So very simple causes. Then what are the pulmonary causes? C. So I can say chronic suppurative lung diseases, chronic suppurative lung disorders. So what are the chronic suppurative lung disorders? Bronchiectasis and cystic fibrosis, and lung abscess, empyema. Anything related to chronic suppression. Bronchiectasis, cystic fibrosis, lung abscess, and empyema. Okay? Or if you want to read, you can write cystic fibrosis as separate C also. But cystic fibrosis, why it causes clubbing? Because it produces bronchiectasis. That's why. Cystic fibrosis is a very important cause of bronchiectasis. Then, of course, cancer. Two cancers can cause both bronchogenic cancer as well as mesothelioma. Both can result in clubbing. So C stands for cancers. Another C stands for cryptogenic. So what do you mean by cryptogenic? Idiopathic. What disease will come under idiopathic? ILD. Cryptogenic na idiopathic. What will come under idiopathic? IPF, idiopathic pulmonary fibrosis. That can cause clubbing. Then coming to GI causes. Once again, in GI, you can think about cirrhosis, okay, which can cause clubbing. Yes. Then celiac disease can cause clubbing, another C. And cancer of the GI tract, especially GI lymphomas, are known to produce clubbing. And final C is congenital. Isn't it? So all are C's only. C. That's the mnemonic for clubbing. So cause of clubbing. Apart from that, you have multiple causes. For example, you can have clubbing due to neurologic cause. If a patient is having hemiparesis, that side you can have clubbing. These are neurologic cause of clubbing. The best example is hemiparesis. In the paralytic limb, they can have clubbing. So that tells you that in the paralytic area, there is abnormal neurovascular function. Because of vascular abnormality only, you get clubbing. So possible in a neurological condition. Second, it could be thyrotoxicosis. Thyrotoxicosis. Another cause of clubbing. These are additional causes. And IBD, this comes in the GIT only, but IBD can well cause clubbing. Inflammatory bowel disease. Minimum, at least these causes of clubbing should be understood. Least minimum. Clear? Okay, now comes the difficult part. So now they will be asking so many questions. What do you mean by the term pseudo clubbing? Where will you see pseudo clubbing? Many conditions, but how will you differentiate pseudo clubbing from your this thing, true clubbing? Two things. Pseudo clubbing will have preserved Lowy bond angle, and their fluctuation will be negative as well. Fluctuation also will not be positive, and their Lowy bond angle also will be normal only. Intact Lowy bond angle and negative fluctuation in pseudo clubbing. This is how you differentiate pseudo from true clubbing. So that tells you the possibility. What is the reason for pseudo clubbing? Why you get pseudo clubbing? Because it is due to bone lysis, acro-osteolysis in the distal phalanx. Because of bone resorption in the distal phalanx, it looks as if it's clubbed. It's an appearance, but because it's a bone lysis, still the Lowy bond angle will be intact and your fluctuation will be negative because there is no proliferation of soft tissue here. It's just a bone lysis. So why fluctuation should be positive? That's why it's due to acro-osteolysis. So pseudo clubbing can be unilateral or it could be generalized. So where will you get unilateral clubbing? Or maybe I'll say unidigital rather than this thing. Unidigital clubbing and generalized clubbing. Unidigital and generalized. Unidigital clubbing is the commonest form of pseudo clubbing. Where you will see that? Subungual tumor, very rare. Subungual tumors. What is the best example of subungual tumors in clinical exams? It happens in tuberous sclerosis. That's called as cone and subungual fibromas. Have you heard of that? In tuberous sclerosis, you will get Sjagren patch, ash leaf macule, And there is something called periungual or subungual fibromas, otherwise called as Conant's tumors. Subungual tumor or subungual cyst under the nail if you have a cyst. Okay, or very rarely if you have an osteoid osteoma underneath. So these are examples of unidigital clubbing, single nail, where you can see generalized pseudo clubbing, generalized condition that produces acroosteolysis, lysis of the bone. Classic example is systemic sclerosis because of significant low perfusion to the distal areas, because systemic sclerosis or scleroderma is a vascular problem, low perfusion to the distal areas. So that is causing clubbing. And apart from that, you can have acromegaly. Acromegaly can cause, and that can cause clubbing. Have you ever heard about that spade-shaped distal phalanx in acromegaly? That's an important MCQ for NEET exam. That spade-shaped distal phalanx itself can cause clubbing. And hyperparathyroidism can cause clubbing-like appearance. It's a pseudo clubbing. That's because of parathyroid hormone-induced bone lysis. And leprosy can produce an appearance like that, but it's not a true clubbing. And some books will give vinyl chloride toxicity, but I'm not very certain about that. I've never seen a case of vinyl chloride toxicity in my life. But anyway, so vinyl chloride toxicity is a thing that's been mentioned. But other things are well-known cause of pseudoclubbing. Okay. Where you get unilateral clubbing. Whenever you have a neurovascular insult in that particular limb. So what are the areas where you get neurovascular insult? Hemiparesis. Sometime back only I told you, no? In the hemiparetic limb, you will have what? Clubbing of that in hand alone. That is unilateral clubbing. Hemiparesis is a typical example, neurovascular insult. Or if you have any subclavian artery problem, subclavian artery stenosis or subclavian artery aneurysm. So that can result in clubbing of that particular hand. Then tell me what other tumor affects the unilateral neurovascular bundle. It's also called as apex of lung tumor. Yeah, Pangos tumor. Because that affects the brachial plexus and subclavian vessels, isn't it? So that's another example of unilateral clubbing. Where we get painful clubbing. Clubbing is painful. It's believed that in bacterial endocarditis, clubbing is painful, maybe because the nail infarcts. Then bronchogenic carcinoma due to unknown mechanism. You get painful clubbing. And in lung abscess, again due to some mechanisms, you get painful clubbing. Where will you get unidigital clubbing? Apart from the causes I've told you before, that's pseudo clubbing. I'm asking about true clubbing, unidigital clubbing. Usual reason for unidigital clubbing is hereditary cause. Some problem while coming in the birth canal or something happened. Hereditary cause is the most common reason for unidigital clubbing. Or some repeated minor traumas will result in fibrotic tissue will proliferate in that area. So repeated minor traumas that is happening for a long time in the nail, that can result in unidigital clubbing. And apart from that, other two well-known causes are sarcoidosis. Probably because the granulomatous infiltration of the nail, you can result in unidigital clubbing, sarcoidosis, and median nerve injuries can produce unidigital clubbing. Can you get differential clubbing? Differential clubbing. What do you mean by differential clubbing? You will see only in the upper limbs, not in the lower limbs. Or you will see only in the lower limbs, not in the upper limbs. Or you might see in 2 upper limbs and 1 lower limb. Or you can see in 2 lower limbs and 1 upper limb. Okay, I'll talk about that in cyanosis, because more than differential clubbing, the differential cyanosis is very important. So typically, common example, where you will get only upper limb clubbing. PDA with shunt reversal. That's where you get upper limb clubbing alone. Patent ductus arteriosus with shunt reversal. I'll show that in cyanosis. I'll show the diagram itself in cyanosis. Patent ductus arteriosus with shunt reversal with Eisenmenger will result only in clubbing in the, sorry, lower limb alone. It's not upper limb basically, lower limb. Lower limb clubbing alone. PDA with shunt reversal. Because where is PDA? I mean, technically asking patent ductus artery is the connection between aorta and pulmonary artery. So that is there near the subclavian artery. Left subclavian artery, the descending aorta. That is the connection, that's where it is located. So what happens is in shunt reversal, the blood starts flowing from pulmonary artery to aorta. Normally the blood should start flowing from, normally the blood flows in direction of aorta to pulmonary artery. But if there is Eisenmenger and shunt reversal, the blood is going to flow from pulmonary artery to aorta. So because the PDA connection is little below or near the left subclavian artery, and the right subclavian artery is here, the deoxygenated blood from the pulmonary artery will enter the aorta a little below the left subclavian artery. So the upper limbs will be spared. That deoxygenated blood will go into the descending aorta into the legs only. So that will cause clubbing in the lower limbs alone. So clubbing in the lower limbs alone is an example of differential clubbing, and one of the most important examples is PDA with shunt reversal or PDA with Eisenmenger syndrome. Or very rarely in upper limb alone, if you ask, I can tell cardiac causes, but practically upper limb alone, if you want to see clubbing in both the upper limbs, not one, both the upper limbs, if you're seeing clubbing means, you can see technically in intravenous drug abuses, because they keep repeatedly injecting drugs in their veins and they will damage their neurovascular bundle in the upper limb. So because of repeated injections again and again and again. So that's another reason why you can get unilateral clubbing. Sorry, clubbing only in the upper limbs. Only upper limb clubbing. Okay, two other things are important in clubbing, which means two other things can cause clubbing. One is something called HOA, that's called hypertrophic osteoarthropathy. Previously, it was called as hypertrophic pulmonary osteoarthropathy. Right now, we don't call by that name. We simply use the term called hypertrophic osteoarthropathy. Does COPD cause clubbing? Technically, answer is no. Okay, COPD doesn't cause clubbing. Very important point. In the entire causes, one C that doesn't cause clubbing is COPD. So because you should not think like COPD being a C, it should cause clubbing. One C that does not cause clubbing is COPD. If there is a COPD patient comes with clubbing, what do you think about? Three possibilities, but the most important is cancer, because most COPD patients are heavy smokers. And once they develop clubbing means you should start suspecting cancer. Examiner will expect that point only. COPD, clubbing, what do you think? Cancer. Or it could be bronchiectasis also, because bronchiectasis is also common in COPD patients. Or it could be ILD also. And again, fibrosis is also common in COPD patients. If you are really looking at the patients, if you are a postgraduate, definitely you will be knowing. Many COPD patients will show fibrosis here and there. Because especially in emphysema, the reason is actually an imbalance between protease and antiprotease. More protease and less antiprotease. So that more protease activity from the neutrophils will damage not only the alveoli, they cause fibrosis also in the long run. So very common in emphysema, you can see fibrosis diffusely. Very, very common. Okay, and bronchitis is also very common in COPD patients in the late stages. So that also can imply that the patient is having a clubbing. So COPD ideally should not cause clubbing, but one thing, single most important point is you have to look for cancer if the patient develops clubbing, especially faster. So what is hypertrophic osteoarthropathy, HOA? So it's a typical triad. Okay. So triad means it will cause periosteosis of long bones. Periosteosis. Periosteosis means there will be a periosteal reaction that you can see in the X-rays. Periosteal reaction. Okay. Periosteosis. Long bones. So which long bones are affected? Tibia is the most commonly affected bone. Invariably affected. Tibia. Okay. Then it can affect any long bones for that matter. Then it can produce symmetric arthritis. Like rheumatoid arthritis, you can have a symmetric arthritis. Okay. Then finally, the third component is the clubbing. Patient can have clubbing also. This is a typical triad of hypertrophic osteoarthropathy. And what is the most common bone involved? As I told you, it's tibia. Okay, most common bone involved. It's invariably involved. Then radius, ulna, fibula. femur, humerus, long bones, any long bone can be involved. But what are the rare or the last bones to be involved? Metacarpals and metatarsals. They are the last. Okay, they don't get involved that early or frequently. Tibia most common, earliest. Then you have radius, ulna, fibula, humerus, femur and all. Then last involvement will be on the metacarpals and metatarsals. Okay, in the X-rays also you can see. And patients can have associated neurovascular changes in the hands and feet. In the hands and the feet, you might see additional neurovascular changes. What do you mean by neurovascular changes? You can see erythema, excessive sweating in those areas, and they can have paresthesia, tingling sensation. So these kind of neurovascular changes are very common in the areas that are affected. So skin changes also can happen in the affected areas. That's what I'm telling, erythema. Okay, tingling sensation, paresthesias, and they can get edema also. Okay, so they can get neurovascular changes. High increased sweating, very common. And there are two types of HOA. One is primary HOA and second is secondary HOA. Primary means idiopathic. We don't know the cause, but that contributes to less than 5% of the cases. Remaining more than 95% of the cases will have some underlying problem. So what is the most important underlying problem? Malignancy, lung cancer especially, bronchogenic cancer. One of the important reasons for developing hypertrophic obstructive, not hypertrophic osteoarthropathy. Okay, next disorder, final, before moving on to next thing is thyroid acropathy. Thyroid acropathy. So remember, this happens only in Graves' disease. It doesn't happen in any other hyperthyroidism. It happens only in Graves' disease. Please understand, hyperthyroidism is different. Thyrotoxicosis is different. First, let me tell you the difference. Then you will understand Graves' disease, because many students have a false notion about what is hyperthyroidism and what is thyrotoxicosis. Remember, you have a broad term of thyrotoxicosis. Okay, so if you say that all of these patients will come under thyrotoxicosis, only a small group of patients will be deemed as hyperthyroidism. So what about the remaining patients? Which means thyrotoxicosis means elevated thyroid hormone, no matter where it is coming from. Even I can take exogenous thyroid hormone and I can get thyrotoxicosis. Even thyroid hormone can come from some ovarian tumor also. That's called struma ovary. That can cause thyrotoxicosis. Or it could be thyroiditis, where the gland is destroyed and released thyroid hormones can result in thyrotoxicosis. But hyperthyroidism means there is elevated thyroid hormone, and that is due to overproduction of thyroid hormone in the thyroid gland. That is hyperthyroidism. It is due to overproduction of thyroid hormone in the thyroid gland. That only we should call it as hyperthyroidism. Which means only very specific conditions like Graves' disease, toxic multinodular goiter, or a toxic solitary nodule. So only these things will come under hyperthyroidism. Thyrotoxicosis, factitia, external thyroid hormone abuse, or struma ovary, or alternatively other conditions like thyroiditis causing destruction of the gland and release. All these things will come under thyrotoxicosis, but they are not true causes of hyperthyroidism. Do you understand or not? That is the reason why we do radioactive uptake scans. Remember, uptake scans are very, very commonly utilized in hyperthyroid patients or thyrotoxic patients. Uptake scans we don't use in hypothyroidism, or even though your surgical textbooks will confuse you a lot, but clinically speaking, uptake scans are most useful in thyrotoxic patient only. Because generally, these patients who have thyrotoxicosis without hyperthyroidism will have low uptake only, because the gland is not the problem here. The hormone is coming from somewhere else. Whereas in patients with hyperthyroidism, your gland will show increased uptake, either homogeneous increased uptake in Graves or heterogeneous increased uptake in multinodular goiter, or there will be single nodule that shows high uptake in case of solitary thyroid nodule that is toxic. So that's why uptake scans are most useful in patients with thyrotoxicosis. You can exactly find out what is the cause. That's why, first of all, this is very important. Under hyperthyroidism, there is one selective cause, specific cause, that is Graves' disease. Okay, Graves' disease has two manifestations. Remember, Graves' is because of what? Antibodies. So you have two important manifestations because of antibodies. One is thyroidal manifestations. Second is extrathyroidal manifestation. Two manifestations of Graves' disease are there, thyroidal and extrathyroidal. But please understand, both are due to what? Antibodies. In that thyroidal manifestation, most often you will see thyrotoxicosis. More than 95% of the patients, you will encounter thyrotoxicosis only. But very few patients may have normal thyroid hormone also, even if they have Graves' disease. That's called euthyroid Graves. So you might not be very much aware of the fact that there is a euthyroid Graves, but that's there. Because the antibodies are of many types. There is blocking antibody, stimulating antibody, and neutral antibody also. For example, if the stimulating antibody is more than the blocking antibody, which is the case usually, you will end up with hyperthyroidism. But if the blocking is equal to stimulating antibody, you will end up with euthyroid state only. But this antibody can result in extrathyroidal manifestations, and this is considered to be very specific for Graves' disease because that directly points out the reason that the reason for this is antibodies. That's why these extrathyroidal manifestations are the most specific manifestations of Graves, rather than the thyroid manifestations itself. So what are the extrathyroidal manifestations? You have Graves' ophthalmopathy, you have Graves' dermopathy, and you have thyroid acropathy. So these are the three typical manifestations of Graves' disease, extrathyroidal manifestations. These are very, very specific for Graves. Okay, compared to the thyroid manifestations itself. Thyroid manifestations, you can see hyper as well as U, but extrathyroidal are very, very important. So in that, what is termed as Graves' ophthalmopathy is a big confusion. So what students tend to diagnose is thyrotoxicosis due to any cause itself will overactivate the sympathetic nervous system. Please understand. Hyperthyroid state or thyrotoxic state itself is a state of high SNS activity, sympathetic nervous system activity, because thyroid hormone potentiates the sympathetic nervous system action of SNS. So because of the high activity of sympathetic nervous system, there will be increased contraction of a muscle called Muller's muscle. Where is Muller's muscle? In the eyelids, both upper and lower eyelids, you have Muller's muscle. What is this muscle? It's an autonomic muscle or voluntary muscle? If I say sympathetic nervous system means it must be what? Autonomic nervous system. So remember, you close your eyes voluntarily with the help of your what nerve? Facial nerve. You open your eyes voluntarily with the help of oculomotor nerve, but you blink with the help of Muller's nerve, Muller's muscle. You don't blink with the help of third nerve or seventh nerve. You blink with the help of autonomic nervous system because it's an automated process. That is the reason why, because of increased contraction of Muller's muscle. Okay, because when Muller's muscle contract, like you tend to increase the palpebral fissure. If the Muller's muscle relaxes, you tend to blink. The eyelids fall down. Both upper as well as lower eyelid go up, meet each other. That's blinking. So if the contraction of Muller's muscle is more, the palpebral fissure will become wide, and that will result in the characteristic thyroid stare. And most of the signs that you study in surgery, Van Graaff sign, Dalrymple sign, all these things can happen in any thyrotoxicosis, not just in Graves' disease. Clear? For example, what is Van Graaff sign? That's called as lead lag. So what is lead lag? See, look at me. When I look up like this and when I look down, it's not just my eyeballs are moving, it's my eyelids are also moving down along with the eyeballs. So in a patient with Muller's muscle that is contracting very heavily, so the patient is looking down, look at me, now the eyeballs will come down, but my eyelids will not come down along with the eyeballs. This lag between the eyeballs and the upper eyelids is what we called as lead lag. And that again signifies over contraction of the Muller's muscle. Second, what is Dalrymple sign? At least 2-3 signs you have to tell, no, in exam. What is Dalrymple sign? Again, due to Muller's muscle retraction only, generally the upper part of the cornea will not be visible. Upper limbus, limbus means junction of the sclera and the cornea. So the upper part of the cornea will not be visible. You can see your friend itself, next person itself. You cannot see the upper part of the cornea, limbus. If the upper sclera and cornea, if the sclera above the cornea is visible, or if the upper limbus is visible, that is called as Dalrymple sign. And that's once again due to increased contraction of Muller's muscle. So these signs are signs of what? thyrotoxicosis, but not Graves' disease. So you should not confuse this Graves' ophthalmopathy with thyrotoxic eye signs. Okay, so what is Graves' ophthalmopathy then? What is Graves' ophthalmopathy then? It is the actual, maybe I can say, whenever there is increased retroorbital pressure, that will result in Graves' ophthalmopathy. So why retroorbital pressure? Because it's believed that fibroblasts contain TSH receptors, and this antibody bind with the fibroblast TSH receptor behind the orbit, and they tend to increase the glycosaminoglycan secretion. And that because glycosaminoglycans are osmotic, they absorb water, and because they absorb water, they swell up, and the peripheral retroorbital tissues will swell up, resulting in increased retroorbital pressure. This is the mechanism, not very important. But anyway, this increased retroorbital pressure will result in venous congestion. This will result in chemosis. Because of poor blood flow, because of congestion, the blood will not flow back. That chemosis. Third, that is called as restrictive ocular myopathy. Very peculiar. Normally, paralytic ocular myopathy is different, where the muscle is not functioning. Here, because of edema and fibrosis, the muscle will not be able to relax properly, and so that it will not allow other muscles to function properly. That is what we refer to as restrictive ocular myopathy. And the first muscle to be affected in this regards is inferior rectus involvement. Number 4, because of that, you can get something called compressive optic neuropathy. Because the high pressure behind the orbit itself, the optic neuropathy and blindness can happen. So if the patient is having significant congestion, the patient is having chemosis or edema of the conjunctiva and the eyelids, if the patient is having restrictive ocular myopathy, if the ocular movements are restricted, first to be affected is what? Inferior rectus. Or if the patient is going for blindness, these are signs of Graves' ophthalmopathy. Congestion, chemosis, edema, restrictive ocular myopathy, or compressive optic neuropathy. All these are evidences of Graves' ophthalmopathy, not the Dahl-Rempel sign or Von Graffi sign. And dermopathy is much less common. For example, clinically, the incidence of Graves' ophthalmopathy is 50%. The incidence of dermopathy is approximately 3 to 5%. 3 to 5%. And the incidence of thyroid acropathy is less than 1%. Okay, so this is the incidence. Generally, Graves' ophthalmopathy can come alone, but dermopathy will never come without Graves' ophthalmopathy. Clinically, when you diagnose a dermopathy, that is pre-tibial mixed edema. The other name for thyroid dermopathy is pre-tibial mixed edema. So if you see dermopathy means 100% you should see what? Ophthalmopathy. It doesn't happen without ophthalmopathy. Similarly, acropathy will not happen without ophthalmopathy. So if you see a thyroid acropathy means you should 100% see a dermopathy as well as ophthalmopathy both together. So ophthalmopathy only can come alone. Dermopathy cannot come alone, or acropathy cannot come alone. You should have company. That's a very important point. Why in clinical practice it's very important? Because mixed edema is a common finding of both hypothyroidism as well as hyperthyroidism. In the same pre-tibial area, you can get mixed edema in both hyper as well as hypothyroidism. So how will you differentiate? Hypothyroidism will never get ophthalmopathy. If it's a pre-tibial mixed edema, definitely you should have what? Ophthalmopathy. So that one clinical sign will differentiate whether it's a Graves' disease or hypothyroidism, causing mixed edema in the tibia. That's why that point is important. Are you understanding or not? So this is the basic background of thyroid disorders. Okay. Otherwise, you won't understand what I'm trying to talk about. Thyroid acropathy in the first place. So it's seen with Graves' disease. Number 1. That's very important. So again, it's a triad. So what triad you see? You see clubbing, of course, here. And you will see soft tissue swelling of the hands and feet. Hands and feet will be extremely swollen. It's very, very classic picture. Soft tissue changes in the hands and feet. And number 3, there will be periosteal newborn formation, periosteal reaction. Periosteal reaction will be there. Periosteal newborn formation. That's called periosteal reaction. So remember, in both HOA as well as thyroid acropathy, you will have periosteal reaction. But how will you differentiate between them? Remember, thyroid acropathy definitely will have associated dermopathy and associated Graves' ophthalmopathy. But hypertrophic osteoarthropathy, why they should have dermopathy and why they should have Graves' ophthalmopathy? So that's why these points are very important. It might look very similar, but all these are very different entities. Hypertrophic osteoarthropathy is generally caused by malignancy. Thyroid acropathy is caused by Graves' disease and antibodies. Don't say thyroid acropathy is caused by hyperthyroidism. That's a wide term. Thyroid acropathy is a specific feature of what? Graves' disease. So now I think you will get it. So what do you mean by thyroid acropathy? So these are the important pointers towards clubbing. Okay, coming to cyanosis, 10 minutes, you can go for break, 6:15 to 6:30, don't worry. I can see a lot of very resistant faces. I mean, more than resistant faces, urgent faces, you can see. Just 5 to 10 minutes. Okay, cyanosis definition around, I'll finish. So what is cyanosis basically, definition wise? It is the bluish discoloration of the skin and the mucous membrane. Like how jaundice is the yellowish discoloration of skin and mucous membrane, cyanosis is nothing but bluish discoloration of skin and mucous membrane. When you look at cyanosis, whenever the deoxyhemoglobin component is more than 5 grams per deciliter, you will get cyanosis. This is the number that you need to know for exams. Deoxyhemoglobin component more than 5 grams per deciliter in the blood. Or if the deoxyhemoglobin exceeds more than 30% of the total hemoglobin. This is not that important, but if some examiners ask, you can say exceeds more than 5 grams per deciliter, or if it exceeds 30% of the total hemoglobin, you're going to end up with cyanosis. This has a huge implication. Why? Because a person who is having anemia, severe anemia. What is the definition of severe anemia? Less than 8 or less than 7 grams per deciliter. So if a patient is having severe anemia, their deoxyhemoglobin can never reach 5 grams per deciliter. So understand, for example, even better understanding, let us assume a patient is having a hemoglobin of only 4. How can a deoxyhemoglobin level become more than 5 grams per deciliter? It's not possible. So that's why an anemic patient, severely anemic patient, may not develop cyanosis at all, despite the fact that they may have a severe cardiorespiratory issue. May not develop cyanosis at all, because their deoxyhemoglobin content may never exceed 5 grams at all. Okay. For the same reason, a patient who's having polycythemia, even if they don't have any cardiorespiratory issue, they can still develop frequent cyanosis. Because a polycythemic patient may have a hemoglobin of 20. In that, achieving a 5 gram deoxyhemoglobin is very easy. Even in normal day-to-day situations itself, you can reach 5 grams per deciliter, so they can encounter a frequent cyanosis. So that is the implication of that, knowing the fact that deoxyhemoglobin should be more than 5 grams per deciliter to produce cyanosis basically. Or alternatively, if your saturation is less than 85% in adults, or if it is less than 70% in children, you can encounter cyanosis. There are multiple reasons why in children saturation cutoff is different. That is because the hemoglobin oxygen dissociation curve, number 1, they will have more of fetal hemoglobin. So that associates with hemoglobin very avidly. So it's very difficult to get low oxygen state. That's one reason. Which means high oxygen affinity means they keep binding with oxygen with high affinity. So how can we receive a saturation of less than 85? It's very difficult. So that's why children have a different cutoff. Second reason is children have a higher hematocrit also. Isn't it? Their hematocrit also will be relatively high, especially in newborns and all. 17, 18 and all will be their hemoglobin. So that's why in newborns and infants, so you don't get very frequent cyanosis unless until your saturation is less than 70. But in adults and younger children, easily you can get cyanosis if the saturation reaches less than 85%. Or alternatively, if you have abnormal hemoglobin circulating in the blood, for example, if you have a methemoglobin, remember that is not methemoglobin, that is methemoglobin. So because I've seen many people pronouncing it as methemoglobin. Meth is wrong. It's not a methemoglobinemia, it's a methemoglobinemia. So what is methemoglobinemia? Hemoglobin will be in reduced form. That is called methemoglobin. And some reducing agents will reduce the hemoglobin in reduced form. So oxidized and reduced, both should come again and again. So here the hemoglobin will reduce form. If the amount of this met hemoglobin or a changed hemoglobin, that's why it's called met, changed hemoglobin, if it is more than 1.5 grams percentage, I mean, technically you can get cyanosis. Or if you have a sulf hemoglobin, and if it's more than 0.5 grams per deciliter, that's called, I mean, that can also result in cyanosis. And whenever the cyanosis due to met hemoglobin or sulf hemoglobin, so that is called as enterogenous cyanosis. Or endogenous, you can think. Because of the hemoglobin abnormality, you get cyanosis. That's called as enterogenous cyanosis, or simply called as pigment cyanosis. It can be called as enterogenous cyanosis, or it can be even called as pigment cyanosis. Okay, that's a different form of cyanosis. Everyone knows that cyanotic congenital heart disease will produce cyanosis. There's no doubt about that. But how much blood should mix to produce cyanosis? At least the right to left shunt should be at least more than 40%, which means for every 100 ml of blood, 40 ml of deoxygenated blood should mix. Then only you will get cyanosis. So only at least 40%, the shunt capacity should be at least 40% shunting should be there. That's why I told you in the beginning, you remember, in physiologic shunting, how much lung should be involved? At least 40 to 50% of the lung should be involved, then only you get cyanosis. So then only you can produce this large shunts. Then only you can get cyanosis. Same thing applies here. Even a macroscopic shunt, you should have at least 40% of shunting. For example, in 100 ml blood, 40 ml of deoxygenated blood should be there. Then only you will encounter significant cyanosis. What are the sites you will look out for cyanosis? Remember, various sites are there, depending on whether it's a central or peripheral cyanosis. Peripheral cyanosis means more in acral areas, the fingers, toes, the earlobes, nose tips and all, you can see cyanosis, very commonly due to cold exposure and sluggish blood flow. Central cyanosis is very pathognomonic for some cardiorespiratory problem. So, where you look for central cyanosis? Oral cavity especially. So lips, again, whether it's inner aspect or outer aspect. So remember, outer aspect of the lips can be seen in peripheral cyanosis also, significant cold exposure. But inner aspect of the lips, very commonly you will encounter only in central cyanosis. But more importantly, the tongue is very important. You can see this perioral lip cyanosis, the tongue cyanosis, the tongue, lips and all is very characteristic of central cyanosis. And the body, the central body, if it's blue, face if it's blue. So these are all indicate what? Central cyanosis more often than peripheral cyanosis. But as you can see here, what is this one? This is a toe discoloration. So this is a very good example of a peripheral cyanosis. But understand, conditions that produce central and peripheral cyanosis will be highly overlapping. Certain conditions can cause peripheral cyanosis and certain conditions can cause central cyanosis, especially conditions that cause central cyanosis can cause peripheral cyanosis also. So there will be a considerable overlap, but ideally peripheral means it's in the acral areas, nose tips or in the earlobes or maybe in the outer aspect of the lips, that's all. But face, inner aspect of lips, oral cavity, palate, tongue, all these things will go towards what? Central than peripheral cyanosis. Okay, I think with this you can go for a break. You can come back in 15 minutes. Maybe I'll start the session by 6:30 again. So I think we have lots to discuss. Then I have to tell about the difference between central and peripheral cyanosis. Then I need to talk about certain things about cyanosis as well. And then we have the ever important lymphadenopathy. And usual areas again where they're going to screw you is the lymph node examination. Because even in my postgraduate medal exam, one of the cases lymphadenopathy. And they screwed me left and right in lymphadenopathy. But I answered that is different, but I'm telling you, it's very difficult. It's not easy when a lymph node case comes. You might think it's simple, but you have plenty of questions. They can go anywhere. They can go to Hodgkin lymphoma, they can go to non-Hodgkin lymphoma, they can go into post-transplant lymphoproliferative disorder. They can go into a specific subtype of non-Hodgkin lymphoma and they can torture you there and they can ask treatment of lymphomas. They can go into TB also. They can go into HIV treatment also. So what not? So that's why lymphadenopathy is very dangerous in exam. Or they can go into some specific malignancy also, solid organ tumor. They can ask treatment of lung cancer and all. If you tell supraocular nodes, you are done and dusted. GI cancer or lung cancer only, mostly. So if it's left means Troisier sign GI cancer. Right means it's a thoracic cancer, very commonly a lung cancer. Both are deadly for an undergraduate. GI cancers, you will not answer properly in surgery itself. And lung cancer will not answer properly in surgery itself. In what way you will answer in medicine and all. So if they don't like you, they will start screwing like this only. So that's why, even if I am very much offended by you, she will say, I don't see lymphadenopathy. But I will ask, if you see lymphadenopathy, what are the DDs? I can easily screw you. It's very easy as an examiner. Okay, so that's why you have to be very careful. Always be very observant and be very obedient, at least on the exam day. Okay, fine. We have been discussing on what? Cyanosis, right? So we need to know the differences between central and peripheral cyanosis. So what is the mechanism behind central and peripheral cyanosis? First of all, the reason for central cyanosis is low saturation. Okay, that is the main reason for central cyanosis. Low saturation means what is the physiological reason? Hypoxic hypoxia or hypoxemic hypoxia, whatever. Okay, hypoxic hypoxia is the reason for what? Or hypoxemic hypoxia, that's the right name. Hypoxemic hypoxia is the reason for developing what? Central cyanosis, whereas peripheral cyanosis is due to sluggish blood flow. Is due to a slow, sluggish blood flow. That is the reason for peripheral cyanosis. So it is also called a stagnant hypoxia. I think you would have heard about that. So mechanism here is hypoxemic hypoxia. There in peripheral cyanosis, it is stagnant hypoxia. What are the sites to look for? Especially the tongue and the oral cavity. That will clinch you the diagnosis. If you see cyanosis here, it is almost always pathognomonic for central cyanosis. Along with that, you can see in the palate, which also comes under oral cavity, of course. You can see in the conjunctiva. Which conjunctiva? Lower palpebral, like where you see anemia. Okay, lower palpebral conjunctiva. And remember, a person who is having central cyanosis may have acral cyanosis also, because same mechanism can cause cyanosis in the peripheral areas also. Okay, so it doesn't mean a central cyanosis patient will have only central cyanosis, not peripheral. They might have associated peripheral cyanosis also. But if you have in tongue and oral cavity, you can be almost always sure it's a central cyanosis. Maybe in the inner aspect of the lips, ideally it's oral cavity only, so that goes towards central cyanosis only. And palpebral conjunctiva also more often goes towards a central cyanosis. Whereas in peripheral cyanosis, acral areas. What do you mean by acral areas? The most peripheral areas. The fingers and the toes, and in the tips of the nose, or in the ear lobes, or in the outer aspect of the lips alone, but not in the other areas of the face. Only the outer aspect of the lips, tip of the nose, and the ear lobes, on the fingers and the toes. So these are the common areas where you have to look for peripheral cyanosis. And what are the associations? Generally, central cyanosis, not acute, chronic central cyanosis will be associated with clubbing and polycythemia. You can experience that in cyanotic congenital heart disease. Cyanotic congenital heart disease. In any chronic cyanosis, you can experience clubbing and polycythemia, but not in acute central cyanosis, by the way. But whereas peripheral cyanosis will be typically associated with cold exposure very often. That will be the history, Raynaud's phenomenon, cold exposure. Or in patients are having connective tissue disorders, which connective tissue disorder is well known for causing peripheral cyanosis, that is Raynaud's phenomenon. Scleroderma, of course, very, very well known for peripheral cyanosis. And next you have local vascular conditions, like some problem in the subclavian artery or brachial artery aneurysm. So some local vascular issue also can result in peripheral cyanosis. But usually it will be cold exposure. That's the main reason. That's because of sluggish blood flow. And extremities in central cyanosis will be warm generally, because the blood flow is not a problem here. Blood flow is okay, but the hypoxia is the problem. Hypoxemia is the problem here. Whereas in peripheral cyanosis, obviously the blood flow is sluggish, so extremities will be cold. On warming the extremities, there will be no change, because already the extremities are warm. If you warm the extremities further, there is not going to be any improvement in central cyanosis. Where in case of peripheral cyanosis, the cyanosis will reduce. It will disappear if it's a peripheral cyanosis. As far as oxygen inhalation is concerned, in central cyanosis, you can see a slight improvement, okay, in central cyanosis. Whereas in peripheral cyanosis, there will be no change. So remember, the problem is not hypoxemia here. The problem is sluggish blood flow. So even if you give oxygen, it doesn't work in a peripheral cyanosis, ideally. And in ABG, you will see low saturation and low PaO2. As I told you, SaO2 less than 85% is one of the important reasons for central cyanosis in adults. So low saturation is the main reason. Here normal. So it's peripheral cyanosis, it's sluggish blood flow. So ABG will not show any abnormality. Saturation and all will be normal only. And pulse volume will be high. That is because of hyperdynamic circulation, hypoxemia. Generally, not always, but pulse volume will be high, especially if it's a cyanotic congenital heart disease. Whereas the pulse volume will be generally low. Why? That is because of vasoconstriction and reduced sluggish blood flow. Your pulse volume will be little low. What about dyspnea? Dyspnea is often the case in central cyanosis. Very, very often it will be there. Whereas in peripheral cyanosis, why you should get a dyspnea? Isn't it? That's all. These are differences between central and peripheral cyanosis. There is one important test called hyperoxia test. So what do you mean by the term hyperoxia test? Hyperoxia test is to differentiate between cardiac versus respiratory cyanosis. So it is a test of central cyanosis only. So whenever you know it's a central cyanosis, to differentiate between cardiac versus pulmonary cause, you can use hyperoxia test. So what is the hyperoxia test? Ask the patient to breathe 100% oxygen for at least 10 minutes. For 10 minutes, you are going to ask the patient to breathe in 100% oxygen. It's very useful in children, especially. In adults, we don't do this. It's very useful in children. So you are going to compare the PaO2. You are going to compare PaO2 before giving oxygen and after giving 100% oxygen. Suppose if your PaO2 increases, if your oxygen increases by at least 100 millimeters of mercury from the baseline value, from previous value, pre-oxygenation and post-oxygenation, if the PaO2 increases by at least 100 millimeters of mercury, this generally tells you that the patient is having a respiratory cause, not a cardiac cause. Cardiac cause is extremely unlikely. If the improvement is less than 100, then cardiac cause is very likely. And once again, different textbooks will give different value. I've taken this from ACCHA guidelines. But Indian textbooks, some textbooks will give 150 millimeters cutoff and all. I'm not very sure. So cutoffs will vary, but this is a very useful test in children especially. Because children, they may have cyanotic congenital heart disease or they may have some respiratory cause also. Respiratory distress syndrome. So to differentiate, you can use 100% oxygen and you can find out. I'll tell the idea. Idea is actually very, very simple. I'll tell you the idea later on. What is the basic principle of hyperoxia test in a while. So what do you mean by Levy test? So Levy test is to differentiate between central versus peripheral cyanosis. I told you, hyperoxia test is to differentiate between cardiac and respiratory cause of central cyanosis. Whereas Levy test is to differentiate between central and peripheral cyanosis. It just works by the principle of warming an organ or warming an area. Okay, don't imagine something wrong. So rubbing the earlobes, that's what I meant. So if you rub the earlobes in a patient with cyanosis, if it's a peripheral cyanosis, that warmth should improve the cyanosis. If it is central cyanosis, there will be no improvement in the cyanosis because it's not related to warmth. So if you have a earlobe cyanosis, if you don't know whether it's central or peripheral, just warm. Just rub the earlobes and warm the earlobes. So once you rub and warm, your cyanosis will disappear if it's a peripheral cyanosis, whereas cyanosis will persist if it's a central cyanosis. Or on the other hand, even more easier thing is your staff nurses will do in the hospital. Even peripheries, you can apply the Lewis test, even though it's originally implicated for the earlobes only, but it can be applied, extrapolated and applied for the peripheral areas also, in the fingers and toes. See, any staff nurse, whenever they see a cyanosis, they tend to what? Rub the fingers. They think it's cold is causing the cyanosis. So it's an application of Levy test only. So once you rub and once you make the part warm, you're going to result in disappearance of cyanosis if it's cold related. If it's not related to peripheral cyanosis, definitely, like the cyanosis will persist. So that's what we call as Levy test. So it's an application of the fact that warming the extremities will improve the cyanosis in case of peripheral cyanosis. That's the application of Lewis test. Okay. Then coming to the causes of cyanosis. So what are the causes? So to know the cause of cyanosis, we need to know the types of respiratory failure. So when you are going to call as respiratory failure means whenever PaO2 is less than 60 millimeters of mercury, it's an objective definition. That is equal to respiratory failure. Whenever PaO2 in your ABG is less than 60, we call it as respiratory failure. That's a critical number that you need to know. So if you know about respiratory failure, there are multiple definitions of respiratory. There are multiple reasons why you can get respiratory failure. So in that situation, you need to look out the PaCO2 first. Your PaCO2 may be reduced or PaCO2. First of all, you need to see A gradient. That's what. Sorry. You have to see something called AO2 gradient. This is theory. I'm just explaining along with sinus. You need to see something called AO2 gradient. If AO2 gradient is increased, it generally indicates a type 1 respiratory failure. Very often. Usually indicates a type 1 respiratory failure. If A gradient is normal, there are two possibilities. Either it could be a type 2 respiratory failure, or simply that's not the correct term. We have to use the term called alveolar hypoventilation. Or alternatively, it could be a low FiO2 state. Low FiO2 state. So what is alveolar hypoventilation? It's a type 2 respiratory failure where the patient is either not breathing properly or the tidal volume is not getting delivered properly. So what is type 2 respiratory failure? It is based on minute ventilation concept. Whenever minute ventilation is low, your CO2 will start accumulating because you are not breathing properly. So your CO2 will accumulate. That is what we call type 2 respiratory failure or alveolar hypoventilation. When the minute ventilation can be low, either if the patient is having low respiratory rate or if the patient is having low tidal volume. So what are the conditions where you have low respiratory rate? If the patient is having central cause like opioid intoxication, benzodiazepine poisoning, head injury, raised intracranial pressure. So any central cause that is affecting the brainstem, you can result in low respiratory rate causing type 2 respiratory failure. Or on the other hand, patients can have low tidal volume means it indicates a neuromuscular cause. If the patient is having poliomyelitis, amyotrophic lateral sclerosis, Guillain-Barré syndrome, myasthenic crisis, so any neuromuscular disorder can result in shallow breaths, low tidal volume. Because of that, your minute ventilation can drop, and because of that, you can result in alveolar hypoventilation, and because of that, you can result in type 2 respiratory failure. So very typical cause of type 2 respiratory failure, easy to understand. Low FiO2 state means classic example for that is high altitude. In high altitude, your ideally FiO2 will not decline. Please understand that's a misnomer by most of the medicos. As you go to the high altitude, your partial pressure is reducing. FiO2 of oxygen remains the same. Even if you hit the stratosphere, FiO2 will remain the same at 21%. But it's the partial pressure of oxygen and partial pressure of entire atmosphere that is reducing as you move up to high altitude. So, based on Dalton's law, your partial pressure of oxygen also will keep reducing. Because of incoming partial pressure of oxygen is reduced, the amount of oxygen that is reaching the alveoli is also less. That is how you end up with hypoxemia. But that is falsely given in the name of a misnomer. That's a low FiO2 state. It's not actually low FiO2. It is reduced partial pressure of oxygen as you go up. That is typical high altitude. That's what is going to cause that picture. So high altitude can cause normal A gradient, and type 2 respiratory failure and alveolar hypoventilation can cause a normal AO2 gradient. So how will you differentiate between them? It's very easy. In alveolar hypoventilation, you are not breathing properly. So your PaCO2 levels will be high. Whereas in low FiO2 state, you're trying to breathe faster because your oxygen that is coming inside your lungs is very low. So because of hyperventilation, your PaCO2 will be low. So the PaCO2 will tell you whether it's a low FiO2 state or whether it's a alveolar hypoventilation. But practical situation where you see low FiO2 state in your ICU, see, high altitude doesn't matter, but practically where will you see? In your common day-to-day setting, whenever the ventilator is disconnected or whenever a bulky staff nurse is standing on the ventilatory tube. Yes or no? Or whenever the oxygen cylinder is not changed properly by the fellow, is slept in the oxygen room. Oxygen central supply is reduced. So these are the common day-to-day situations where you see this situation rather than high altitude. Okay, high altitude is physiological condition, but more than that, you can see that in any common day-to-day life in these situations which I have told you. So based on PaCO2, you can easily understand. When you talk about type 1 respiratory failure, you have multiple situations. So next thing what you need to ask yourself is whether the patient is desaturating only on exercise. Desaturating only on exercise or not. At rest he is completely comfortable. If yes, then it indicates a condition called diffusion limitation. That's called diffusion limitation. If they desaturate only on exercise. If they are not desaturating on exercise, which means they are desaturating at rest itself. In the sense, they are desaturating at rest itself, which means at baseline state itself, they are desaturating and they are going for respiratory failure. If this is the case, this indicates either a VQ mismatch or a shunt formation. VQ mismatch or a shunt formation. So how to find out? You need to give 100% oxygen to these patients. Hyperoxia test, I told you, no? You have to give 100% oxygen. If the 100% oxygen responds, and if your PaO2 rises to more than 60, then it indicates a VQ mismatch. VQ mismatches can be just managed with your 100% oxygen itself. If still your PaO2 is less than 60, means if your oxygen is not working, means there is some shunt that is happening, significant shunt. I told you, more than 40%. Either it could be anatomic or it could be physiologic shunt formation at the pulmonary level. So you have to think about something called as shunt formation. Shunt formation, once again, there are multiple causes are there. For example, what are the cause of VQ mismatch? Which means VQ ratio can be more than 1 or VQ ratio can be less than 1. So, for example, let us assume you have an alveoli and you have a capillary where you have VQ ratio of less than 1. Suppose if there is reduced ventilation to this alveoli, ventilation is still happening, but if it is reduced, but the perfusion is normal, perfusion is okay, not badly affected, but ventilation is reduced. So in this situation, what will happen? Because the numerator is decreasing, but denominator is almost okay, your VQ ratio will decrease and will become less than 1. So what are the conditions where ventilation is reduced? Patients are having obstructive lung disease. So whenever you talk about obstructive lung disease, there are 4 classic conditions: COPD, bronchial asthma, cystic fibrosis, and bronchiectasis. Okay, these are the 4 classic obstructive lung diseases: COPD, asthma, cystic fibrosis, and bronchiectasis. 4 classic obstructive lung disease. And VQ mismatch can happen in patients with ILD itself because of a lot of reasons. In fact, ILD, the most important reason for hypoxemia is VQ mismatch only. Even though ILD classically produces what? Diffusion limitation. ILD classically produces diffusion limitation, but that does mean it's the most predominant mechanism of desaturation and hypoxemia. And second classic example of diffusion limitation is emphysema. These are classic to classic example of diffusion limitation. That is why you take your textbook and see today, if you are studying Davidson or Harrison or whatever textbook, when you see a difference between chronic bronchitis versus emphysema, chronic bronchitis is type B, emphysema is type A, you know. So what is the major difference? They would have given in emphysema, there will be desaturation after exercise. In chronic bronchitis, you don't see that because emphysema is a condition that produces diffusion limitation. That's why in emphysema, you have desaturation on exercise, but you don't get that with chronic bronchitis, which is not a condition that produces diffusion limitation. Each and every word has a meaning. That's why you won't see today itself. In every textbook, it's given as a difference between emphysema and chronic bronchitis. So one restrictive lung disease that produces diffusion limitation is ILD, and a classic obstructive lung disease that produces diffusion limitation is emphysema. These two are very, very important. Even in your sleep, if they ask you, you should be able to tell this. And any interstitial lung disease can produce excess desaturation. Classic example is COVID itself. COVID is an example of viral pneumonia. Viral pneumonia is an interstitial pneumonia. And one of the characteristic feature of ILD is desaturation exercise. What is the exercise that you do for the patient? You don't ask the patient to lift the dumbbell in the hospital. You ask the patient to walk for some time and come back. You see for the saturation, the patient desaturates, it indicates an ILD or an emphysema probably, depending on the situation. clinical history and the other clinical background. That's why COVID is an example where patients desaturate on walking because it produces interstitial disease, interstitial pneumonia, or any viral pneumonia, reticular pneumonia for that matters, can have this desaturate on exercise. In exam, in any NEET PG exam or USMLE exam, if you go, PCP pneumonia, which is a typical example of interstitial pneumonia, will classically show desaturation on exercise. So anything that affects the interstitium will have diffusion limitation. That's the idea. Okay. Then what about VQ more than 1? VQ more than 1 means your ventilation is okay, but your perfusion is reduced. So because numerator is okay, denominator is decreasing, your VQ ratio becomes more than 1. So what are the examples of low perfusion? You're going to talk about shock, or any shock, especially cardiogenic shock. See, in cardiogenic shock, it's not only perfusion with the other organs that is reducing. Even for the lungs, it is reducing. Or any patient who's having pulmonary hypertension, okay, because of reduced blood flow to the lungs, but the ventilation is okay. Okay, pulmonary embolus can produce, but actually in pulmonary embolus, the VQ ratio is infinity because the blood flow in that area is 0. So anything divided by 0 is infinity. But again, that also comes under pulmonary hypertension, pulmonary embolus also. So many conditions are there, but most classic example is cardiogenic shock itself, where you can produce VQ ratio of more than 1. I told you in shunt formation what is happening. Here the alveoli is completely collapsed. It's not working. Collapsed, or it's filled with something else. Okay. And remember, at least more than 40 to 50% of the entire lungs should be involved to produce significant shunt. So in this situation, your right side blood is directly shunted to the left side blood, again in significant amounts. If it's only very few, 5% or 10% alveoli, you will not get any significant shunt, so that there won't be any cyanosis or any problem. But if more than 40 to 50% of the blood is getting shunted like this, you will end up with a problem. So to get a shunt at a microscopic level, at a physiological level, it should be either a bilateral diffuse process in the lung, or it should be a unilateral complete collapse. So if you have a unilateral complete collapse of one particular lung, 50% of the lung is gone. Or it should be a bilateral diffuse severe disease to produce more than 40% involvement of the lung. So easily you can differentiate with the help of a chest X-ray. In the chest X-ray, in the evidence of 100% oxygen that is not working, if you see a bilateral disease in chest X-ray, it indicates something called as diffuse alveolar filling, or something called as alveolar filling process. So what do you mean by alveolar filling? Something is filling the alveoli. It could be pus, which is equivalent to pneumonia, or it could be water, which is equivalent to pulmonary edema. Remember, pulmonary edema could be either cardiogenic or non-cardiogenic. Cardiogenic is left heart failure, non-cardiogenic is ARDS. Or alternatively, it could be blood also, which is referred to as something called as diffuse alveolar hemorrhage. Yes or no? Which commonly happens in vasculitic patients, diffuse alveolar hemorrhage. Pneumonia, pulmonary edema, diffuse alveolar hemorrhage. Classic conditions. In these conditions, the alveoli is filled with something else, and that is not allowing the ventilation to happen. That's called alveolar filling process. And if it's a unilateral complete collapse, what will be the usual causes? Either it will be a tension pneumothorax, classic example, or it will be a complete collapse due to some other cause. Like for example, endobronchial intubation. Have you ever heard of endobronchial intubation? So what is that? Especially this happens in a newcomer, freshly joined postgraduate. I mean, whenever you are a first timer, what you in anxiety, you tend to push harder. When you want to push something into something for the first time, you don't know what to do, and you tend to what? Push harder and deeper. And that can cause trauma to the throat. I mean, with the endotracheal tube, of course. Isn't it? That happens. That's what happens. So in urgency, you can push deeper into a hole that you don't want to. That is the right bronchus. Isn't it? So right endobronchial intubation means that goes to the right bronchus so that the left lung does not receive any air at all. So it starts collapsing. Endobronchial intubation. Very common in the right bronchus because right bronchus is more straight and not angulated. That's why, like the passage should be straight to go deeper, isn't it? So that's why right bronchus is easily acclimatizing this hard pushes. Okay. So then what about your other causes? It could be a massive effusion or an empyema on one side that can completely collapse. So these are examples of total collapse. Easily you can find out. And shunt also means what? It's not just alveoli, it can be what? Not microscopy, it can be anatomical shunts also. Anatomical shunts are not very important in ICU except for the children, neonatal patients. Anatomical shunts means it could be a cyanotic congenital heart disease or it could be a Eisenmenger syndrome. Okay, it was initially a not acyanotic, but later on as they develop Eisenmenger, they'll become what? Cyanotic congenital heart disease. Number 3, what? Probably pulmonary AV malformations, as I told you already. Morning I said no, pulmonary AV fistula, pulmonary AV malformation. So some macroscopic shunting also can happen, but this is not very important as far as adults are concerned. So for adults, these are very important. The microscopic pulmonary physiologic shunts are very, very important. These are you assess. Which means why I told you is, I told you the treatment of respiratory failure itself. So whatever I told you here, every single cause will result in cyanosis. COPD can cause cyanosis, emphysema, bronchial asthma can cause cyanosis, any obstructive lung disease can cause cyanosis, or shock patients can have central cyanosis, cardiogenic shock especially. You can have pulmonary hypertension, pulmonary embolism can cause cyanosis. Okay. Tension pneumothorax, endobronchial intubation, massive effusion, severe pneumonia, severe pulmonary edema, diffuse cellular hemorrhage, all these things can cause central cyanosis. And cyanotic congenital heart disease, Eisenmenger and pulmonary AV malformations also can cause central cyanosis. So almost everything what I have told you here are causes of central cyanosis. Same way you understood the approach to respiratory failure also. So how will you manage a shunt basically? See how will you manage a shunt basically? These shunts you can't manage that easily. Okay, you need some special process, okay, some surgery or something. It's very difficult to manage these shunts. Anatomical shunts are not managed in the acute setting. Very difficult to manage. You need to do some squatting and so many other things you have to do. We'll discuss later on in TOF. Tomorrow I'll discuss on TOF. That time I'll tell you. Unilateral complete collapse, most of the time, the treatment will be instantaneous in unilateral complete collapse. For example, you need some basic intervention. Some basic intervention. That's all. That's all you need. Some basic intervention. So for example, tension pneumothorax means as an urgent maneuver, you put a needle in the second intercostal space in the mid-clavicular line or in the fifth intercostal space in the mid-axillary line, or followed by a chest drain. So that's the basic treatment. If it's an endobronchial intubation, be calm. Don't push harder. Okay, try to withdraw the tube a little outside. Things are going to be fine. If it's massive effusion, put a chest drain. Tap the effusion, put the chest drain. Things are going to be fine. So most of the time, interventional things itself will clear off the unilateral massive collapse. This alveolar filling, the problem is alveoli is either completely collapsed or alveoli is filled with something else. So you have to remove that. So you have to give some treatment for what's happening. If it's a pulmonary edema due to cardiogenic cause, give Lasix. If it's a pneumonia, give antibiotics. If it's diffuse cellular hemorrhage, treat the vasculitis with immunosuppressive drugs. Alternatively, as an urgent therapy to save the life of the patient, you need to open the collapsed alveoli by giving positive pressure ventilation. So what do you mean by positive pressure ventilation? You give a positive pressure to open up the alveoli. So remember, the idea of giving positive pressure is not to oxygenate, it is to open up the collapsed alveoli. So if the idea is oxygenation, if the problem is oxygenation, means they should have responded to what? 100% oxygen. If they do not respond to 100% oxygen, the next step is going to be positive pressure ventilation. That's all. That's how we decide in the ICU, when to intubate or when not to intubate. Are you understanding or not? That's all. So every single cause I've told you here can result in what? Central cyanosis. Okay. So in the same time, you understood your approach also. So if at all I ask you about central cyanosis, any condition that produces VQ mismatch or any condition that produces shunt formation will result in what? Central cyanosis. When you talk about peripheral cyanosis, reduced cardiac output, congestive cardiac failure, because of sluggish blood flow, you can get peripheral cyanosis. Vasoconstriction, for example, cold exposure, Raynaud's phenomenon, and vasoconstriction can happen in what? Any shock for that matters, because of heightened sympathetic nervous system discharges can result in peripheral cyanosis. Or arterial obstruction can result in peripheral cyanosis. What are the examples of arterial obstruction? Burger's disease or simple peripheral vascular disease, common in the lower limbs. They can produce what? Peripheral cyanosis. Or venous obstruction can produce peripheral cyanosis. What is the example of venous obstruction? SVC syndrome. In SVC syndrome, you see cyanosis of the face and the neck, edema and cyanosis of the face and neck. Very common, isn't it? Because the blood is not draining. More venous blood, congestion, you get cyanosis. That is because of sluggish blood flow, right? It's not because of hypoxemia. So it's a kind of peripheral cyanosis only. Best example. Then, if the patient is having hyperviscosity will produce sluggish blood flow. Okay, so obviously, like you would have studied Pascal's law, isn't it? In that, what they said is, in hyperviscosity, the flow will be reduced because of the viscous nature of the fluid. Water versus oil, which will flow faster? Obviously, water. Oil will flow slower because of hyperviscosity. Same thing. What are the examples of hyperviscosity? Multiple myeloma because of immunoglobulins, or polycythemia because of more RBCs. Hyperviscosity. And many other conditions can result in peripheral cyanosis like MS, very, very important. Mitral stenosis. Mitral stenosis is about to cause peripheral cyanosis only. Why? Because in MS, the mitral orifice is very small. So the amount of blood that's going into the left ventricle is very small. So by Frank-Starling law, the left ventricle receives lower blood. So the force of contraction will be less. So ventricle will be very lethargic. Slowly it will be contracting. That's what is producing the tapping apical impulse. Okay. So MS is a cause of central if it produces pulmonary edema, and peripheral because of MS itself. So can cause peripheral cyanosis. MS is a typical example of peripheral cyanosis in early stages without pulmonary edema. But as you can see here, many conditions have overlapping central and peripheral cyanosis. For example, low cardiac output in congestive cardiac failure can have central as well as peripheral cyanosis. Shock can produce both central as well as peripheral cyanosis. Then MS can produce what? Both central and peripheral cyanosis. So there will be, and many causes of central cyanosis can have what? Peripheral cyanosis associated. That's why it's very difficult to find out exact cause. But if you have a central cyanosis, means you have a significant cardiorespiratory issue. That much you should know. Peripheral will not tell you what is the exact problem, but central, if it's there, very likely you need to think about a cardiorespiratory problem. That's why we have that testing. What is that? Warming test or Lewis test to differentiate between central and peripheral cyanosis. And there are some special types of cyanosis. One is differential cyanosis. Differential cyanosis. As I've told you already, this is a typical image of a PDA. As you can see here, in a patent ductus arteriosus that has reversal option. Normally in a patent ductus arteriosus, the blood should go from aorta to pulmonary artery. But if there is Eisenmenger syndrome and reversal option, the blood is going to move from pulmonary artery into the aorta if there is shunt reversal. So which means this deoxygenated blood is mixing with oxygenated blood. In this situation, this oxygenated blood, deoxygenated blood or improperly oxygenated blood is the one that is going to the lower limbs, and that's why you get only lower limb cyanosis here. Okay, so that's why it's a differential cyanosis. You get only lower limb cyanosis. So the best example of isolated lower limb cyanosis is PDA with shunt reversal. So if you want to tell the best example for upper limb cyanosis only, then reverse the arteries. For example, instead of, if this pulmonary artery is arising from the left ventricle, and if this aorta is arising from the right ventricle, what is it called? Yeah, that's called TGA. I mean, there is a corrected as well as not corrected TGA. Tomorrow we'll discuss LTGA and DTGA. But transposition of great vessels with PDA, with shunt reversal, of course, it's a reverse of what we have seen. It will produce what? Upper limb cyanosis only. That's all. Just reverse the arteries along with PD and shunt reversal, you will get what? Only upper limb cyanosis. Typical example. Or if you want to see lower limb plus left upper limb cyanosis. I mean, some books will give this upper limb cyanosis as reverse differential cyanosis. I don't know what is that. Some books will give you that, especially Indian author books may say, but doesn't mean. Differential cyanosis means you see only in particular limbs. That is differential cyanosis. I don't know what is reverse differential. I mean, these are all typical Indian words. Reverse differential, paradoxical. These are all Indian examiners words. Some books will give that's reverse differential cyanosis, but I don't agree with that. So it's a differential cyanosis you see only in selected parts of the body. That is differential cyanosis. So lower limb and left upper limb alone, where you will see. It's very simple. Suppose if there is a PDA with shunt reversal, okay, you have a PDA with shunt reversal, but if the PDA opening is proximal to the left subclavian, this is the left subclavian artery, right? Remember, beyond the left subclavian, the aorta becomes descending aorta. We all know the anatomy. So till the left subclavian, it is aortic arch only. Below the left subclavian, it's descending aorta. So suppose if the PDA opening is what? Proximal to the left subclavian in certain patients. Now this deoxygenated blood, okay, will not reach only the lower limbs. It will reach what? The left arm also through the left subclavian. So the same story, PDA with shunt reversal, but PDA is opening proximal to the left subclavian. Yes or no? Same PDA with shunt reversal, but PDA opening is proximal to left subclavian, and that will cause lower limb plus left upper limb cyanosis also. Opening proximal to left subclavian. And another type of cyanosis, this is an old paper. I don't know why. That's called intermittent cyanosis or a transient cyanosis. This is a very old paper. If you want to know how old it is released in 1958. NEJM article. In that first time, the author used the word intermittent cyanosis for patients who are suffering from Epstein's anomaly. That's why Indian examiners even now ask that question. That's an outdated term again. Epstein's anomaly, cyanosis depends on a lot of other factors. How much atrialization of the right ventricle is there, it depends on that factor, not on intermittency and all. But anyway, that word is described in Epstein's anomaly. That's why Indian examiners might expect that. But there's another approved word. This is not old, this is even used now. That's called cyclical cyanosis, where you will see that it's an ENT condition. Bilateral choanal atresia. I think if you are third year student, you will be able to say, or if you have just finished third year, you will be able to say. In bilateral choanal atresia, you will get cyclical cyanosis. Why? Huh? Yeah, that's all. When the baby is crying, baby is going to breathe through mouth. So fine, cyanosis will get resolved. When the baby stops crying, closes the mouth, choanal atresia cannot breathe. So they will get cyanosis. That's why it's called cyclical cyanosis. During crying, no cyanosis. Stops crying, cyanosis. So it's very, like ironical, isn't it? Baby cries means cyanosis will resolve. Okay, problem will solve. When the baby stops crying means problem will start. Very, very ironical. Okay, that's called cyclical cyanosis, bilateral choanal atresia. Then we have something called orthocyanosis. You can yourself say where you get orthocyanosis. What do you mean by orthocyanosis? Morning I told you already the basics. Standing erect, you get cyanosis. Very commonly, it will be associated with orthodeoxyplatypnea syndrome. So what will be the cause? Pulmonary AV malformation, ASD, and your epidopulmonary syndrome, all nonsense. That is what we call it as orthocyanosis. The same thing that produces orthodeoxyplatypnea syndrome is going to cause orthocyanosis. Then we have something called pseudocyanosis. Typically happens in drug-induced hyperpigmentation. Okay, because some drugs like amiodarone can produce bluish pigmentation, right? So it will be very commonly in drug-induced cases. I'll show you some drug-induced hyperpigmentation. And certain cytotoxic drugs. What are the classic example of cytotoxic drugs that can produce hyperpigmentation? Bleomycin. Okay, they can produce that streaks of, I'll show you the picture, streaky hyperpigmentation. Okay, that is bleomycin, or it can happen with busulfan. Or it can happen with cyclophosphamide, sometimes rarely. Cyclophosphamide, bleomycin, and busulfan. Some anti-epileptic drugs, can produce this, that is phenytoin especially. And certain antipsychotic drugs can produce hyperpigmentation, especially phenothiazine. Whenever you call phenothiazine, it is chlorpromazine. So very classically, chlorpromazine, if you take for a long time, it can result in hyperpigmentation. So what are the cardiac drugs? Cardiac drugs means amiodarone, most importantly, that can produce hyperpigmentation. Then minocycline, very, very well known for hyperpigmentation. Any tetracycline can produce discoloration, you know that, but minocycline has the highest tendency to produce skin hyperpigmentation and teeth discoloration and all. And it can happen with heavy metals, especially gold. It can produce a kind of yellowish color to your body, gold. That's why we had a famous political leader. Many people have that kind of, I don't know whether it's a myth or whether it's a fact. It's believed that our ex-political leader, Dr. M.G. Ramachandran, MGR, here like how NTR, like there it is like MGR. Both are like synonymous, okay? So both superstars of different states, both become CMs. That gave the wrong idea to many heroes that they can become politicians and CM. I mean, they become means that is because of their mojo and a lot of other issues. And the timing, everything is there. But many heroes, even now, they believe that they become CM. I don't know how. Okay, and they speak all the mass and punch dialogues without any use. I mean, sometimes, you know, like if you keep repeating the same thing again and again, you start believing things. That's what I believe these heroes believe things. They keep speaking the same punch dialogues multiple times in multiple movies. So they start believing, even if they are not capable, they believe that they are capable to do all this. That's an irony, isn't it? So that's what I don't take notes of all this, please. I'm not expecting you to take. See, whenever, see, problem is like I can't understand her. She's enigmatous. When I am writing, she's not taking notes. Whenever I'm saying this kind of nonsense, she's taking notes. So which means you feel like life lessons are more important than, you know, like the actual theory. That's what you feel, I think. Maybe second probable reason, I know I look extremely smart, but that doesn't mean you have to keep looking at me all the time. You also have to see the note and write something at times. Okay. 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 All right. Cool. You know, like that guy is telling what a confidence this guy has on himself. That's what people are thinking. Okay, you need confidence, isn't it? At any time. Sometimes, you know, like it should not be overconfidence, but at least you should have some self-confidence on yourself. Okay. Fine. So pseudocyanosis. One of the causes is gold. So this is an example of characteristic bluish gray hyperpigmentation on a patient who's taking long-term amiodarone. So generally, if they take amiodarone for at least 20 months only, they will develop what? This kind of hyperpigmentation. Just with 2 or 3 months of amiodarone use, it's very unlikely. Long-term amiodarone use, at least for 20 months by definition, they will develop this kind of bluish gray hyperpigmentation. What is this? This is a minocycline hyperpigmentation. You can see around the mouth. So that's a very typical area, and it can produce generalized hyperpigmentation elsewhere in the body also. That's an example of a minocycline hyperpigmentation. And this is, you can say, bleomycin, because that produces what? This streak-like hyperpigmentation. Okay, typical example of a bleomycin-induced hyperpigmentation. I mean, I don't know how you can confuse with cyanosis, but the only logical thing I felt that you can confuse cyanosis is this one, because at least to some extent you can see that bluish tinge in the face, and also to some extent you can confuse other things. I don't think you can confuse with cyanosis. So anyway, what do you mean by endogenous cyanosis? I told you already, no? If it's an abnormal hemoglobin causing cyanosis, that is called what? Endogenous cyanosis or pigment cyanosis.